hyponatremia is one of the common endocrine emergencies which is encountered in pediatric practice, and this is one of those conditions which is quite important in terms of the overall clinical perspective and in terms of challenges in terms of diagnosis and management. Hyponatremia can be because of excess free water, which is or hypervolemic with low uric acid, or sodium loss, which is hypovolemic with high uric acid. Excess free water may be cardiac, liver, or renal disease. You will have edema. You can see very easily in that scenario. Urinary sodium will be low. So volume status is very important. You may have reduced loss because of SIADH. And remember, cortisol deficiency and hypothyroidism are differentials for excess reduced loss in that perspective. Sodium loss could be extrarenal due to diarrhea or cystic fibrosis. Urinary sodium will be low, or renal, in which it could be tubular abnormalities like diuretic and tubulopathy, or RAS defect, in which you have a combined defect. Tubulopathy and diuretic use will have hypokalemia. RAS defect will have hyperkalemia, high potassium in that regards. And your urinary sodium will be high both in SIADH and renal loss. So if you look at this grid, what you need to understand is that if you know about three things, basically, you know about the volume status, you know about the urinary sodium and the potassium level, you can very easily classify which is the cause of hyponatremia.
Classified, and the etiology can be told whether there is any excess of any extra water or the sodium is being lost from somewhere. So let's go to the excess free water. It can be due to overload conditions such as cardiac failure, liver failure, renal disease, where the body has water, but it perceives it as low water because there is decrease in effective circulating volume. Or there is reduced loss such as SIDH, cortisol deficiency, and hypothyroidism. Where the body is actually losing sodium, it could be via the kidneys or extrarenal. In the kidneys, it could be due to a tubular defect, due to drugs or actual tubulopathy, or an actual RAS defect where there is aldosterone deficiency. This deficiency may be combined or isolated aldosterone deficiency such as in PHA. Extrarenal causes, the sodium is being lost by the skin such as cystic fibrosis or the GI tract and diarrhea. Now, as sir mentioned, just to reiterate, the urinary sodium is an extremely useful tool. Now, what it signifies, where the urinary sodium is low, that mentions that there is hypovolemia. That could be effective hypovolemia or actual hypovolemia. What is happening here? There is ADH secretion, but also aldosterone is being secreted to reduce the sodium from the urine. So there will be urinary sodium less than 25. But where there is actual euvolemia or urinary sodium might be high is actual SIDH or cortisol or hypothyroidism, or actual renal loss of sodium where urinary sodium is more than 25. So urinary sodium makes an extremely important investigation in these conditions. Uric acid also is an important condition to see whether hypovolemia is there. So low uric acid means there is enough volume, maybe euvolemia or hypovolemia. High uric acid means there is hypovolemia. Now coming to first gastrointestinal losses, this is the most common cause, and not just the loss, it is the replacement of fluid with hypotonic fluid which causes the loss. So what exactly is happening here? There are GI losses. So that GI losses causes the body to become hypovolemic. This hypovolemia causes high AVP release. Now we already have increased free water because AVP is being released. But if we add hypotonic fluid, there is an excess of free water which causes the sodium to crash suddenly. In these cases, again, urinary sodium is less because aldosterone is being secreted to reduce the urinary sodium loss. Again, coming to the other causes, if there's a decreased effective volume, it is very similar to that. High AVP is present, urinary sodium less than 25, and it worsens with hypotonic fluid. Yeah. Now coming to SIDH. What happens in the SIDH, the body is actually normovolemic. ADH should not be released, but there's an inappropriate release of ADH with normovolemia. So what happens here is basically now, so there is again high AVP under the setting of normovolemia. Now understand, because there is normovolemia, urinary sodium is not affected because aldosterone is not released so high. And again, because of normo or even hypervolemia, ANP is released, which increases urinary sodium to more than 25. And again, urinary osmolality is adequately increased at more than 100. So SIADH can be caused by various pathologies such as CNS pathology, tuberculosis, brain abscess, porphyria as the case mentioned, pulmonary caused infection, the child is on ventilation, malignancies, various drugs, and a rare but important cause is the V2 receptor activation, that is the nephrogenic SIAD. Here the SIADH is present, but the increased activation of the receptor causes ADH-like activity, but the ADH levels might be low. Now coming to the endocrine deficiencies, any case, if you find features of SIADH-like picture, the first thing we should do is to rule out endocrine deficiencies, because the treatment here is not fluid restriction, but to treat the underlying cause. The picture will be very similar to SIADH. There is decrease in free water excretion, but most importantly, ACTH decrease will not cause potassium because the RAS axis is not touched. FT4 has no connection with potassium, so potassium will be normal. Urinary sodium will be high, and fluid restriction is dangerous in these cases. Now, as mentioned, adrenal insufficiency might be primary or secondary. Primary adrenal insufficiency because it's only ACTH involved. Cortisol will be deficient, but normal axis. Low ACTH will not cause any pigmentation. But when we come to the receptor problems such as MC2R, MRAP, or AAA, there will be pigmentation. Again, because only ACTH is involved, there will be normal potassium. The most dangerous and the most severe ones will be the primary adrenal insufficiency, which might occur in the hemorrhage, infiltration, and most commonly CAH. In these cases, there will be pigmentation, and the sodium loss will be much more in severity and will be associated with hyperkalemia. Now, salt wasting CAH, the most common cause of primary adrenal insufficiency in children. Of course, there are various types, but most commonly 21-hydroxylase deficiency is something which should be looked out for. Now, according to where the defect is, such as Smith-Lemli operates, look for 7 DHC levels. Star SCC will have low distal metabolites. 21-hydroxylase, we all know, is 17 OHP levels. So, according to whatever defect, salt wasting will be occurring in these defects. Now, coming to decreased aldosterone levels, and more commonly pseudohypoaldosteronism. Pseudohypoaldosteronism basically caused due to either the mineralocorticoid receptor defect, which might be a slightly less severe disease, but a more severe disease might be caused by the autosomal recessive problem, that is the ENaC defect. There might be systemic involvement, and transient causes include UTI, obstruction, and these are reversible. So what we need to know in decreased aldosterone levels, basically, because of decreased aldosterone, the sodium will be lost and potassium and hydrogen will be retained. So this might cause temporary hyperkalemia, high aldosterone levels in that condition. So these are the various causes of PHA, which I just mentioned previously. So now Bartter syndrome. Bartter syndrome is another important cause. What really is happening here is basically in the ascending loop of Henle, we have a defect in the sodium potassium 2-CC. Now this basically causes increased sodium, increased sodium in the distal tubules in the collecting duct. Now because there is increased sodium in the collecting duct, what really happens here is that all the positive ions, there is increased exchange causing positive ions such as hydrogen and potassium to go into the tubules, associated with calcium and magnesium also in the tubules. So what we are seeing here is hypokalemia, alkalosis, hypercalciuria, hypermagnesiuria, and low calcium and magnesium. Similarly, in Gentleman syndrome, where we have a defect in the NACC defect, again increased sodium in the tubules, causing loss of potassium and hydrogen. So again, hypokalemic alkalosis. But one thing to differentiate here, we do not have hypercalciuria, but we do have hypomagnesemia and hypermagnesiuria like the previous syndrome. Cerebral salt wasting syndrome, again, this is a highly debated topic, whether it is actually an entity or not an entity, but most of the studies and most of the evidence is going towards it being a separate entity. Now it may be caused by various conditions, mostly seen in head injury, such as subarachnoid hemorrhages or brain tumors, causing either decreased sympathetic effect, leading to decreased renin, or more importantly, all the natriuretic peptides which cause sodium loss. The biochemical picture might be very similar to SIADH, which causes a problem initially, but how to differentiate it is usually hypovolemic. Urinary sodium is high, like in SIADH, but differentiating this from SIADH, urinary sodium will be very high, and urine osmolality will be increased accordingly. Urea might also be a very good differentiating factor.
Dr. Linda is talking about what is about a case of very low sodium and normal potassium. This is an unusual scenario, and generally speaking, I have seen a couple of cases with severe MPHD who can present like that. Sometimes you can have severe SIADH because of a nephrogenic SIADH, which can cause, but this is an unusual scenario. If you talk about sodium levels less than 110 or 120, that will be unusual. Usually 120 is okay. Less than 115, that becomes difficult. Dr. Rajiv Das is asking what would be the initial food in a 6-year-old child with body weight 20 kg admitted involved with Japanese encephalitis so that hyponatremia can be prevented. So generally, more people are more talking about in terms of more fluids, which is appropriate, more physiological rather than the hypoosmolar foods. So Dr. Pratik, what will be your take on somebody who has a JE?
Sir, initially we are at a risk of developing hyponatremia. So more than the fluid, it is the regular monitoring of the fluid which we should do. Because normal saline, we can see whether how the sodium is dropping or rising more than exact fluid we are giving.
Generally, we should look at the maintenance fluid, whatever is recommended for anybody else. There is no routine recommendation to restrict fluids in that setting or to really look at different fluids. You'll monitor the sodium. That is more important because it may not develop in many cases. You will have normal, and then giving less fluid may be a problematic scenario. Dr. Rajib is also asking about volume status in kwashiorkor. That's again an interesting scenario. So then uric acid may be a role in that perspective that will give you a picture in that regards. It will behave more like a fluid third space loss scenario. So more like a CCF or a liver disease or nephrotic syndrome. Dr. Ashubu is asking, when looking at rate of fall, what should be the interval between the requests? So generally speaking, that will depend upon the severity. I would say 3 to 4 hourly will be reasonable in that regards. If you're giving an infusion, then you have to be more careful, but 3 to 4 hourly is good enough. Dr. Subhash is asking low sodium, low potassium. The most common cause I would say would be diuretic use. That's what we encounter less in children, more in adults, but that's the most important cause. Rarely diarrhea with inappropriate ORS will be the second scenario. The third would of course be tubulopathies, but diuretic use number one would be that in that scenario.